Hello everyone. Today we'll start one new topic, that is trigger finger. Okay, we'll see here uh, what is trigger finger. Trigger finger is a painful snapping phenomenon that occurs as the finger flexor tendon suddenly pull through a tight A1 pulley portion of the flexor. Okay, trigger finger, otherwise known as stenosis flexor tenosynovitis. Okay, so a flexor tendon may become trapped by a thickening at the entrance to its cyst. On force extension, it passes the constriction with a snap. Or a secondary nodule can develop on the tendon. It's most commonly occurs in MCP joint. Okay. So next is pathophysiology. The pathophysiology of trigger finger is an inability of the two flexor tendon, that is flexor digitorum superficialis and flexor digitorum profundus, to slide smoothly under the A1 pulley. It results in a need for the increased tension to force the tendon to slide and a sudden jerk as the tendon nodule suddenly pulls through the constricted pulley. Okay. So anatomy. Is there two types of pulleys there? Like one is annular pulley, another is crusade pulley. So annular pulley are composed of single fibrous band, and crusade pulley is composed of two crossing fibrous band. So the order of pulleys like proximal to distal, like the A1 pulley. The A1 pulley overlies the MCP joint, and the A2 pulley overlies the proximal end of the proximal phalanx, and the A3 pulley lies over the PIP joint, and the A4 pulley lies middle of the middle phalanx, and A5 pulley overlies the proximal end of the distal phalanx. So like that, in crusade pulley also, like three types, like C1 pulley overlies middle of the proximal phalanx, C2 pulley overlies over the proximal end of the middle phalanx, and C3 pulley overlies uh, distal end of the middle phalanx. Okay, so uh, okay, then here you can see the metacarpal, proximal and middle and distal. In there, the metacarpal joint, in there the nodule is forming. Okay, so here see in the anatomy part, the thickened nodule on the flexor tendon pops through the A1 pulley during a deep finger or thumb flexion, strikes the A1 pulley during attempts to extend the digit, making it difficult, often painful, to stretch the finger or thumb. Next, coming to next is etiology. It may be caused of congenital, it may be repetitive trauma, medical conditions, some of the rheumatoid arthritis and gout, diabetes, hypothyroidism. Okay, so mainly people with rheumatoid disease may develop a synovial thickening or intratendinous nodules, which can also cause triggering. Okay, and one more cause is repetitive or forceful use of thumb. Okay, next one is incidence is most commonly affected in women than men, and is like 40 to 60 years old most commonly affected, and who are more suffering, farmer, industrial worker, musician, they are suffering more. Okay, and then so next one is what are the clinical feature we will get here. most commonly any digit can affected, but the thumb, ring and middle finger most commonly affected. A tender nodule can be felt in front of the MCP joint, and the thick may be reproduced at the side by alternatively flexing or extending the finger. Catching or popping sensation in the thumb or finger, pain when bending or straightening finger, and the stiffness. Okay. Then next coming to clinical anatomy, clinical condition we can get, that infertile trigger thumb. Uh, if both the IP joint and the MCP joint are flexed, okay, both the IP joint and MCP joint flexed because of congenital insufficiency of extensor mechanism, that is infantile trigger thumb. So what are the treatment we can give? In treatment, that is first rest medication, non-steroidal anti-inflammatory drugs, corticosteroid injection for reducing swelling, and then conservative management, splinting of the finger in extension to prevent trigger. Um, then uh, prevent trigger, and some of the protocols is there after trigger release surgery. What are the physical therapy, like there 0 to 4 days, like gentle active MCP, PIP, DIP joint range of motion exercise. In 4 days we have to remove the dressing and remove the dressing and cover wound with band-aid. 4 to 8 days continue range of motion, and 8 days to 3 weeks active assisted range of motion, passive range of motion MCP, PIP, DIP joint, and above the 3 weeks like range of motion activities, strengthening activities that we can give. So in according to what you can provide splint. Okay. Then next one is complication. What are the complication we will get if we are not getting treatment? Okay. So maybe that finger will be incomplete extension, persistent triggering, bow stinging, infection. These are the things we can get. And here's some multiple choice questions regarding this trigger finger. Um, Hope it will be helpful for everyone. Thank you. Thank you for your patience.